For today, we're going to get into acid-base imbalances and their associated conditions. Remember that we are buffering hydrogen as our acid, and our chemical equation down there, which it goes from left to right and also right to left. And we are focusing on bicarbonate, HCO3, which is mediated by our kidneys, and carbon dioxide, CO2, which is mediated by our lungs. Jumping into the respiratory side, remember our normal CO2 levels are 35 to 45. Anything greater than 45 is an acidosis. Anything less than 35 is an alkalosis. So remember again, CO2 levels and pH move opposite of each other. So as my CO2 levels rise, my pH is going to go down and vice versa. In a respiratory acidosis that is acute, that is not compensating quite yet, your CO2 level, you're going to see it high above that 45, our normal range 35 to 45, so above 45. But if we look at our bicarb level, the HCO3, your bicarb level is going to be normal. So some common causes of respiratory acidosis that are acute are acute asthma attacks, acute pulmonary edema, and also think your opiate overdoses, right? So anything that is causing either carbon dioxide trapping within the lungs, like asthma and pulmonary edema, or hypoventilation, like your opiate overdoses. On the chronic side of things, so you have a respiratory acidosis that is chronic. That means you have a respiratory acidosis, so the respiratory side is the primary culprit. But the metabolic side, your kidneys have had time to compensate. So here, our carbon dioxide levels, again, they are too high, they're above 45, but also our bicarb levels are wonky. So our bicarb levels are also going to be high, above that 26. Remember, our normal range, 22 to 26, are also outside the normal range. So here, think COPD is probably one of the most common occurrences of this. You have a patient living with COPD for years and years and years. They are trapping carbon dioxide, and over time, the kidneys are going to respond to that and compensate by withholding bicarb. So that bicarb level is going to go up. Remember, when bicarb level goes up, so does the pH. So we've got a respiratory acidosis. Our pH is low. The kidneys with that bicarb, they're retaining bicarb, are responding by trying to increase the pH level and bring it back inside the normal range. So your long-term COPD patient, their pH may be within that normal range of 7.35 to 7.45, but CO2 is going to be high, and their bicarb levels are also going to be high. With respiratory alkalosis, so your pH is too high, above that 7.45 level. Here with respiratory alkalosis, with respiratory being the primary culprit, your CO2 level is going to be low. Remember, CO2 and pH move in opposite directions. So your CO2 is going to be less than 35, but your bicarb is going to be normal because it is uncompensated. This is acute. So any acute, think hyperventilation, right? So I'm blowing off lots of carbon dioxide. Your patient may still complain of shortness of breath. If it's just straight hyperventilation syndrome, they may complain of dizziness. They may even have carpal pedal spasms. But in this acute respiratory alkalosis, our carbon dioxide levels are low, driving our pH high, but it hasn't had enough time for our kidneys to respond by shifting bicarbonate levels. Other conditions that will create an acute respiratory alkalosis, think pulmonary embolism. Here, with that PE, it is creating hyperventilation, which is in and of itself, you're going to be blowing off excessive CO2, but that is an acute state. So is fever. If you have a fever, your body is responding to that fever with tachypnea. You may be blowing off some CO2 and going into a respiratory alkalosis. On the chronic side, for respiratory alkalosis, Not very common, especially for the pre-hospital provider, emergency care. But for the chronic side, it's been going on for a while, right? So your CO2 levels are below 35, you're blowing off CO2, but it's been enough time that your kidneys have responded and they are excreting bicarbonate, right? So your HCO3, your bicarb levels are going to be low. We see this in aspirin toxicity, aspirin overdoses later on in the cycle. Also with hyperthyroidism, our pregnant patients later term may show a little bit of respiratory alkalosis with that metabolic compensation, just as the normal process, and that will resolve after the pregnancy. On the other side, our metabolic side, remember our normal HCO3 bicarb levels, 22 to 26. Anything less than 22 is an acidotic state. Anything greater than 26 is an alkalotic state, because bicarb levels and pH travel in the same direction. So as my bicarb level goes down, so does my pH. So we'll start briefly with metabolic alkalosis. Since it's fairly uncommon and most of the time caused by us, perhaps we've given a little bit too much sodium bicarb as a medication. And respiratory compensation is pretty ineffective, because for a metabolic alkalosis, we would have to compensate with a respiratory acidosis, which means we would have to have the patient retain carbon dioxide. And that's hard to do without creating hypoxia. It's hard to hypoventilate our patient, right? So with this metabolic alkalosis, it's hard to compensate for without making the patient worse. With metabolic alkalosis, your CO2 is going to be normal. So we're going to see an acute alkalosis. We're not typically going to see a compensated chronic alkalosis here. So our acute metabolic alkalosis, CO2 is going to be normal, and our bicarb levels are going to be high. Typically, again, maybe we've given a little bit too much sodium bicarb, we've caused the issues. Also, excessive Lasix use and excessive diuresis use may lead to a metabolic alkalosis. So will hypokalemia, kind of throws off our electrolyte balances. Treatment-wise, if they are hypokalemic, we can give potassium. And if they have excessive diuresis, we can rehydrate to try to correct the issue. Now, metabolic acidosis, much more common. Our bicarb levels, HCO3, are going to be less than 22, because bicarb and pH go in the same direction. So bicarb goes down, pH goes down. It can either be uncompensated, so it's an acute issue, wherein carbon dioxide levels will be normal, somewhere around 40, so that 35 to 40 normal range, or it can be more chronic, and we're getting into respiratory compensation, in which your carbon dioxide levels will be less than 35, because the lungs have kicked in and they are blowing off carbon dioxide to try to bring that that pH level back up, because CO2 and pH move in opposite directions. Now let's complicate things a little further, because metabolic acidoses, they come in a couple different flavors. One is non-anion gap metabolic acidosis, and the other is anion gap metabolic acidosis. So what is anion gap? Well, it's a little formula looking at your electrolytes and your bicarb. The typical formula looks at sodium and the difference between sodium and your chloride levels and your bicarb levels. There are a couple other formulas out there, but this is the most common one. Normal anion gap, which you'll get off of a lab sheet. Normal is 3 to 10. Anything higher than 10, we're going to call an anion gap metabolic acidosis. So we see in metabolic acidosis, we look at the anion gap. It's greater than 10. We're going to have it that high anion gap metabolic acidosis. If it's not greater than 10, we're going to have a non-anion gap metabolic acidosis. But the most commonly, more commonly, is that anion gap metabolic acidosis, which we'll get into now. So for your high anion gap metabolic acidosis. We have determined we're in a metabolic acidosis. We look at the anion gap, it's greater than 10. Now let's throw a mnemonic at you, which is mud piles, or A mud piles. These are the common culprits of anion gap metabolic acidosis. So heavy alcohol use, methanol or ethylene glycol ingestion. Looking at renal failures and uremia, DKA and sepsis, lactic acidosis. DKA and sepsis are super common anion gap metabolic acidoses that we will see as paramedics. All of these are going to show up as anion gap metabolic acidoses. If you have a metabolic acidosis, then you look at the anion gap, and the anion gap is normal. It's not one of those A mud piles, mnemonic issues going on. More commonly, for normal anion gap metabolic acidoses, looking at some sort of Addison's disease or a flare-up of Addison's disease, ongoing GI issues, lots of vomiting, diarrhea, or excessive diuretic use. As always, send along and share any questions you may have.